Preconception counseling, another fairly light topic. Again, you guys are going to know a lot about this stuff. I have no conflicts. We're going to review preconception counseling, how to implement changes, and recognize women who should be referred. A lot of this is going to be almost repetitive from what we've talked about today, so it will be a fairly quick lecture. Like I said, there may not be anything earth-shattering here. I think it's just good to review things every so often because we do let things slip. We focus on one thing and forget about another thing, so I think it's always good to review. Preconception care is preventative care aimed at women for the purpose of optimizing pregnancy outcome. Why? Because we have women who are not always doing yoga and being fit, as we know. They get pregnant and we would like them to be healthy so that we can have healthy children. What's the barrier to that? Well, up to 50% of pregnancies in this country are unplanned. Sadly, at least 27% of women of childbearing age are obese, and certainly there's room for improvement there. And pregnancies to women over the age of 35 have more than doubled since the 1990s. And we really need to talk to them about specific health concerns. Prenatal care is not a good idea. I'm going back to the ancient Spartans who ordered maidens to exercise themselves to the end that the fruit they conceived might, in strong and healthy bodies, take firmer root and find better growth. The Old Testament, the angel of the Lord appeared unto the woman and said unto her, Behold, now thou art barren and bearest not, but thou shalt conceive and bear a son. Now therefore beware, I pray thee, and not drink wine and strong drink, and eat not anything unclean. And I do give credit for these slides. I heard this from Dr. Belstos in the Fertility Center, and I just thought it was such a great opening that I have completely stolen it, but I will give her credit. In the present, ACOG, AMA, March of Dimes, CDC, they all recommend that we have a reproductive health plan. So it's more than just contraceptive counseling or more than preconception counseling, it's a reproductive health plan. So when we see our patients, would you like to be pregnant in the next year? What is their desire for pregnancy, their timing, their number of children? If they say no, contraception general advice, have a discussion, age-related, about reproductive potential and consider egg freezing. Women are under the impression that just like, you know, all the superstars in Hollywood, they can have a baby at 54, 55, and it's not going to be a problem. Let them know that it is a little bit of a problem. And yes, if they say yes, they want to be pregnant, you want to do preconception counseling. So you want to do a targeted history, and we're going to go over all these different things. Diet and exercise, I think we've kind of beat that to the ground. We know that if you have a high BMI, your risks of pregnancy are much increased. Your risk for gestational diabetes, hypertensions, macrosomia, large babies with potential difficult delivery. If you're underweight, we worry about small for gestational age babies. Remember that our weight gain and pregnancy recommendations are based on a pre-pregnancy weight. So you might want to tell people that if they want to, again, that we are going to base things on their pre-pregnancy weight and not their pregnancy weight, and so they really need to optimize that if they can. And it's always amazing to me to look at what the actual weight gain recommendations are versus what the weight gain that we see in pregnancy actually is. Weight loss, again, nutritional counseling, we've talked about bariatric surgery, restrictive or malabsorptive. ACOG does not distinguish between the two, and again, metabolic and bariatric surgery. Obesity Society and American Association of Clinical Endocrinology still recommend no pregnancy for 12 to 18 months. We talked about the risk. There's a meta-analysis from 2018 of 2.8 million women, 8,000 of whom had bariatric surgery. And yes, it did make a significant impact on decreasing their risks in pregnancy. This is relative risk, but it did increase the risk for small for gestational age, IUGR, and preterm deliveries. Again, this was in the malabsorptive group, so there is a difference between the type of bariatric surgery. Interestingly, there was no difference in preeclampsia, neonatal ICU, stillbirth, malformation, and neonatal death. Special diets, again, I always talk to patients when they see me at the first prenatal visit about what their diet is, but it's important to know we have increasing number of vegetarians and vegans. We really have to make sure they're getting good protein intake, lactose intolerant, calcium supplement. Pregnancy or not, again, exercise 30 minutes a day. We have no real restrictions during pregnancy. Again, I caution people that it's probably not the best time to be water skiing, horseback riding, or doing things that require balance, as simple as riding a bicycle. People who are doing this at a very high rate will likely continue to do it anyway, but you have to warn them about that change in the center of gravity, right? Pregnant people fall down. And again, after 20 weeks, not flat on their back. Smoking, again, high motivated time for people to quit. So when you're talking about them getting pregnant, like we've heard multiple times, people are really motivated. And they're motivated when they're pregnant. If they are planning a pregnancy, it's better to have them stop all these things before they're pregnant. We all know that. Alcohol, no known safe amount, so you have to talk to them about alcohol consumption. Marijuana, I think we touched a little bit on that. It is transferred across the placenta. And in the breast milk, there are data that have inconclusive outcomes. It's amazing. There's just a survey that came out not long ago. Women don't perceive marijuana as a problem in pregnancy. They think it's safe in pregnancy. And they're using it especially increasingly for hyperemesis. And so they're using it during that first trimester, during organogenesis, and I think that's a little bit concerning. Cocaine, we know the risks of IUGR, abruption, preterm labor, low birth weight, as opposed to continued developmental delays and problems with kids afterwards. Narcotics we talked about. But again, when you see this in a history, also think about the social situation. And they may want to work on that a little bit before they bring a baby home. Marijuana, this is just the latest ACOG opinion in 2017. I know there's a lot of new things coming out about marijuana, especially as it becomes legalized recreationally in more and more states. But 2 to 5% of women and up to 28% in certain populations continue to use use marijuana, and 34 to 60% of them continue to use it during pregnancy. So they're not seeing it as a problem. Animal models, the cannabinoids do play a role in fetal brain development, and receptors for them are present in the human fetus by 14 weeks. So we do worry about cognitive development. I mean, we're worrying about it in our teenagers up to the age of 26, or our young adults up to the age of like 26. So why would somebody at 14 weeks, you would imagine that this is really a problem. First month exposure, there's a slightly increased risk of anencephaly, not significant. At or beyond 20 weeks, there is an increased relative risk of stillbirth, and there is low birth weight and increased risk of preterm delivery. Cognitive school performance, varied results. Again, I think over the next couple years we're going to get a lot more data. And these studies are difficult to do. In the past, the socioeconomic tobacco use were confounders. Again, as these drugs become more available and legalized, I think we're going to get rid of some of those confounders. A lot of people know that smoking is bad in pregnancy, but they don't know that marijuana is. So I think we're going to have a lot of things kind of coming out in the next couple years. ZIKA, remember ZIKA always has to be on our radar. Always review travel plans with people and refer to the CDC travel map. CDC travel map changes very acutely, so you need to check it not only when they plan their trip, but with their visit, but tell them to check it also before they go. Right now, I think there's no areas on the CDC map. The last time I looked at it, there were no cases of ZIKA reported, and so now it's down to ZIKA potential areas as opposed to ZIKA risk areas. If somebody does have travel to one of those regions, for the women, of time to accept attempted conception, if they have potential exposure, 2 months from exposure. If they develop symptoms, which can happen a couple weeks later, it's 2 months from the time of the symptoms. For men, it's 3 months exposure, 3 months symptoms. So it's important to also talk to women who have partners who travel quite a bit, because if the men are exposed, again, unprotected sex should not occur during pregnancy. Intimate partner violence. We should be screening everybody every time for intimate partner violence, for abuse, to know if they're safe at home, safe at work. In ACOG back in 2007, estimated prevalence is 23% of women who are seeking prenatal care. We do know that intimate partner violence tends to escalate during pregnancy, so we want to make sure, again, preconception and at your initial prenatal visit, you want to ask about that. In the intimate partner violence in the year prior to pregnancy increases the likelihood of complications in pregnancy as well that may be directly related to the violence, or maybe as a result of living in the violence. And these patients can also have some substance abuse disorders. Medications, review all prescription. Remember the non-prescription medications, change to pregnancy-friendly drugs. I think we've been talking about this. Folic acid, can't emphasize enough. Folic acid, it's amazing some of the interventions, the simple interventions we do. 3 months prior and first 12 weeks, we decrease neural tube defects by 72%. So being able to take a supplement that is cheap, over the counter, easy to take, easily tolerated, and have that significant of an impact. If you have a high-risk pregnancy or a person who is high risk, family history, personal history of neural tube, or a prior baby, diabetes, sickle cell, anti-seizure meds, you want to give them a higher dose, both preconception and through pregnancy. Remember, any of the over-the-counter vitamins will have enough folic acid in it, or people can just take folic acid. That's very well tolerated, especially those first 3 months, when often the prenatal vitamins can cause some of that nausea. Vaccination, we all know to check that rubella is up to date. We all want to at least talk to people about varicella. We're not screening varicella antibodies anymore in the office, because it's not recommended by ACOG. We didn't find it cost effective because the exposure rates were so low, but a lot of people do screen. Remember that both rubella and varicella, you have a 2-month wait for either pregnancy prior to getting, for either vaccine prior to pregnancy. But both of them have significant potential bad outcomes in pregnancies. Influenza, all pregnant women, any trimester during flu season, they should all be getting their flu shot. People around them should be getting their flu shot. The Tdap, we know, not updated preconception, because all pregnant women are recommended to have it at every pregnancy to protect not only the mother, but also for the passive transfer of the antibodies to get to the baby, so that the baby is protected during the first 3 months of pregnancy, during the first 3 months of life, and before it can get its own vaccinations. So the recommendation is anytime after 24 weeks, although we mostly give it a little bit later in pregnancy. We try to wait till about 32. Medical problems. All medical problems should be addressed in terms of both the effects of pregnancy, right? Pregnancy changes everything, and the effects on the pregnancy. Medications optimized, referrals to medical specialists beforehand, high-risk pregnancy physicians, even consults with neonatologists are important. Diabetes, I think we've kind of beat diabetes. Remember that when your hemoglobin A1C increases, your risk of congenital anomaly increases 1.2 odds ratio for every standard deviation. It goes above 6.5, so you really want to get that stabilized. Hypertension, we've talked about. We want to specifically get that controlled, get them on the right medications. Thyroid disorders, remember that thyroid is really important in pregnancy. I know that as a gynecologist, when people come to me and they have a TSH of like 9, but a normal free T4, and they don't get treated because they're not symptomatic, it gives me like chest pain, because we keep our TSHs down to less than about, overall less than 3, 2.5, around 2. And so we know that universal screening is not recommended. Yesterday, I think we talked about in diabetics we should be screening thyroid. Okay, so in diabetics we should be screening thyroid, but universal screening is not recommended, although a lot of people do it. I know our infertility friends do it all the time. We actually have on our chart, we will actually write whether somebody is on thyroid medication because they're hypothyroid, or if they're infertility hypothyroid, because the infertility hypothyroids are usually not generally hypothyroid, so we worry a little bit less about chasing. They usually have like anti-peroxidase antibodies, but their thyroid function is fine. But we still do follow them. Once a person has a positive pregnancy test, they should immediately increase their thyroid by up to at least 20%. The easiest way to preconception counsel patients for that, and I'm waiting to get things thrown at me from over there, make sure it's the soft microphone, is just tell patients as soon as they have a positive pregnancy test, be in touch with either us, their endocrinologist, or we cheat and say just add a couple extra doses per week of your thyroid medication. Just increase by double your pills twice a week and get in as soon as you can so that we can follow. Seizure disorders, again, this is mostly about counseling, making sure you're optimizing medications, trying to change to pregnancy-friendly medications, and instituting your folic acid. Seizure disorders, unclear if it's from the seizure disorder itself or the medications that treat seizure disorders, but there is a 2 to 3 times higher risk of congenital disorders, mostly neural tube, cardiac facial abnormalities, cleft palate. So we want to look at that. Thrombophilias, screening is not recommended unless you have somebody who's high risk. If you have somebody with a known thrombophilia, they may or may not be anticoagulated when they're not pregnant. So make sure that preconception, they know that when they're pregnant, they're going to need to start anticoagulation. Because the recommendations for this change so frequently, anybody with a thrombophilia who is not anticoagulated, we will get a high-risk pregnancy consult prior to guide us to what anticoagulation, what degree, and the timing. Because I know in some of the lower risk patients, we're now only anticoagulating in the postpartum period, which is the highest risk time, as opposed to doing it throughout the entire pregnancy. So we are generally asking for advice on that. HIV, this is another place where, you know, our intervention of medication is incredible. Decreased vertical transmission from 25% to 1%. I just find that always remarkable that somebody can live inside a body that is HIV infected and even without treatment only be 25%, and with medications down to 1%. And again, the biggest risk of transmission is at the time of delivery. You need to know that viral load so that you know how you can deliver that patient. You want minimal blood exposure to the baby. Family history, the brave new world of genetics. Do you all do your own genetics? Do you have genetics counselors? We're very spoiled. We send every pregnant patient to the genetics counselor, which helps us to not have to keep up a lot on genetics. I know it costs a lot of money, but there are reasons that we do it, and I'll explain. Okay, we all know autosomal recessive, autosomal dominant. You carry it. you have the disease. So if you have 2 carriers, you have 25% risk of baby having a disease, right? We remember that from basic science. So how much screening for genetic disorders is enough? Right now, for universal screening, all ACOG recommends is a cystic fibrosis and SMA, hemoglobin electrophoresis to screen for sickle thalassemias, antibody, hemoglobin E disease, and Fragile X. That's all that they recommend through ACOG. In the Ashkenazi Jewish population, the Jewish heritage profile, also hard to keep track of. Right now it's up to about 17 disorders. And in speaking with my genetics counselors, what they're finding is now that we're doing so much more of the expanded carrier testing, there are more disorders that will probably be expanded to this because they're finding higher incidences in the Jewish, Ashkenazi Jewish population. Expanded carrier screening is a comprehensive genetic screening test. You use a single tube or a buccal swab. We actually do it by tubes. You look at both parents, but if you can't look at both parents, please look at least one parent, because if the mom's not a carrier, it doesn't really matter what the dad is, because the worst they can be is a carrier. It looks at about 100 or more diseases that have bad outcomes. It tests for these, and these, and these, and these. And I have to tell you, since we've started doing this, this is like a flashback to medical school, because people come in and say, I'm a carrier of primary hyperoxaluria type 2. And I'm like, huh, that doesn't sound good. The purpose of genetic testing, and ideally it should be done preconception. Other countries, other nationalities really kind of have this up on us. I have several couples from Turkey. And in Turkey, you get screened, and they will tell you whether or not you can be married. And if you don't screen compatibly, you can't be married. But they also don't give you the results of the test. I'm not sure why. Maybe you'll try to substitute somebody. But anyway, so we have a lot of immigrants from Turkey who come in. We get it from Rutgers, and I'm sure from all the universities, you get a lot of grad students and students that are coming from other countries. And we have a lot from the Middle East. And they are so pre-screened before they're even allowed to get married. But I don't know that you should preclude somebody from getting married, but at least they're getting their preconception screening. It certainly gives you reproductive choices. You can choose not to marry that person if you want, or you can choose to have donor egg, donor sperm. You can choose to have pre-implantation diagnosis and IVF. The reason that and this is going to be why, the reason that we send our patients to genetics when they're pregnant is because of insurance. Everything comes back to insurance, right? But you got to be aware of this. These are not cheap tests. If we order the test ourselves, depending on the insurance, they get a huge bill for it. If we send them to the genetics counselors and the genetics counselors order the test is much, much cheaper, like $99 cheaper versus, a couple thousand. So it's a big difference. The problem is when somebody's not pregnant, insurance does not always, without a family indication or a family history, pay for genetic counseling. But when you're pregnant, they will pay for genetic counseling. So they've cornered us in to waiting till they're pregnant to send them to genetic counseling to get the test cheaper so that it can all get paid for. So it's not the optimal setup, but it certainly is an option. And again, we talk about, we have to do things that people can afford to do. We have to be conscious of it. Again, if you have one of these, early intervention to affected offspring is also important. And you can also do testing after somebody's pregnant, which is what we usually wind up doing, is an amnio to check for chromosomes. You cannot, if you do the non-invasive testing, the NIPS that you do from the arm so you can pick up the baby's chromosomes, you can't get these, lots of times you can't get the little micro arrays and you can't get specific. If we do manage to send a genetic screen on one of our patients before they're pregnant, which is ideal, and they come up positive for something, we then refer them to genetics because it may not be as simple, depending on the disorder, as just screening the father. And so the genetics counselors will know exactly what, there's usually a more complicated barrier of tests that they may have to undergo, especially if they screen positive. So again, I told you this be quick. Last minute thoughts. I added the bottles in, no plastic bottles. I added that in last night. If you look at my slide, probably about 2 a.m. because I was like, oh my God, I didn't have that in there. So we added that in. Other last minute thoughts. Ask about workplace exposures, chemicals, dust. You can get maternal safety data sheets. Most states will have an agency that will go in and inspect. My favorite patient for this was somebody who came in and she said, you know, she was already pregnant, and I said, well, what do you do for work? And she said, I work at the zoo. I was like, wow, that's really cool. What do you do? She's like, I take care of the tigers. I'm like, wow. She goes, is there any risk to that in pregnancy? I'm like, well, the tigers can eat you. And she's like, well, that I know, but in pregnancy, is there any risk? So we had to have this frantic literature search. Do tigers carry toxoplasmosis? And then we realized that she's throwing them raw meat, and we're like, oh, yeah, this is like, and she's shoveling their poop and throwing them raw meat, and we're like, all right, just try to stay away from the tigers. We did test her, and she was immune to toxo, so we're like, as far as we know, they said that if they got her out of the tigers, they could put her into the rodent area. And I'm like, yeah, right. I'm like, just can you sell tickets at the gate or something for a while? So she stayed with the tigers and she did well and she came back. But the funny part is that her husband, think about, these are people I want at my dinner party. Her husband was an undertaker. And she's like, well, we live in the funeral home. Is there any problem with the, I was like, you gotta go. You know, it's like, I can't do this, but she did fine. And I always think of what a lucky kid, right? Your mom's a zookeeper with the tigers. Wouldn't that be fun? Anyway, okay. So you need to ask, and I always find it, that's one of the things I find I love best about this job, is talking to people about what they do. People are fascinating. If you take the time, I know we don't have the time, but if you take the time to talk to them, people are fascinating. Discuss home safety. There's really not a whole lot of home safety things. You just want to keep things well aerated, windows open, fans on. You know, everybody's pregnant and painting a nursery, and they're always worried about what to do with the nursery. Again, infectious disease prevention, cat boxes, hand washing. You know, we kind of all know those kind of things. Advanced paternal age. I'm just going to touch on advanced paternal age. Since the 1980s, infants born to fathers of advanced paternal age have increased from about 4 to about 10%. Now, one of the problems is none of the reviews or studies have a good universal definition of advanced paternal age. It's probably higher than 35 than like it is in women. It's probably 45 or more, but according to the ASRM, it's age 40 and greater. Now, advanced paternal age is not entirely benign, despite what we think, or the general feeling in the population, right? Men are fertile forever, women, you know, you have that biological clock. It is associated with decreased fertility. It is associated with an increase in pregnancy complications of diabetes, IUGR, and preterm delivery. And these are studies that have accounted for maternal age, maternal weight, maternal medical conditions. So there's something independent about that. There are complications in the baby. There are increased chromosomal and non-chromosomal anomalies that can be traced back to paternity. And what's even more frightening is the childhood complication. There is increased autism, increased schizophrenia, and an increase in childhood cancers. So advanced paternal age is not as benign as it sounds. Now, The risks of these are low, but they are increased, and they are significantly increased. Again, you're significantly increasing a low-risk thing, but you are increasing it. So this was a review that Justin and that group, we worked together, and so Dr. Bachman and I, you guys know Dr. Bachman, we were talking about this one day, and we're like, wow, that's really frightening stuff. So we published an article in Maturitas that we said, well, maybe there should be an advanced paternal age. Maybe men have a biological clock as well, and maybe we should talk about our men who are delaying childbirth or fatherhood, not childbirth. Men who are delaying childbirth, maybe we should talk to them about sperm banking, right? Freezing sperm is not that hard, and it works really well. So maybe, I don't know, if you have a 45-year-old, a 40-year-old, a 50-year-old, I don't know. Nobody knows the right age. All I know is that we got 4 million phone calls from 4 million news agencies and 4 million magazines after we published that. But anyway, finally, think preconception, all women of reproductive age and men. Don't disappoint the Spartans, God, most importantly, ACOG. You can put your society there. The end.